In the words of Dr. Spielvogel from Philip Roth's Portnoy's complaint, I think at the end, psychoanalyst, so to begin, okay? So my name is Neal Spira, and I'm a psychiatrist and psychoanalyst, and I am the president of the Chicago Psychoanalytic Society and the associate dean of the Chicago Institute for Psychoanalysis. And I've worked in lots of different vicissitudes of the mental health system. And I would like to extend a welcome to you intrepid souls who have decided to join us today as we take on one aspect of what our conference organizers have described as a Sisyphean task. Now, I know you will recall that Sisyphus was a mythological figure, king of Corinth, who was punished for chronic deceitfulness by being compelled to roll an immense boulder up a hill, only to watch it roll back down and to repeat this action forever and ever and ever, basically providing a connotation of endless labor and futility. I'll refrain from interpretation on that regard. But the use of mythology places us in good company here, because from Freud onward, the process of looking inward has led to myth. For Freud, the compelling myth was that of Oedipus, who could not avoid the fate of killing his father and marrying his mother. For Heinz Kohut, a prominent Chicago psychoanalyst, and for Christopher Lasch, who was a historical historian, a cultural historian, it was the myth of Narcissus, who was attracted to a pool where he saw his own reflection in the water and fell in love with it, not realizing it was merely an image, and unable to leave the beauty of this reflection, Narcissus died. In general, I think our Sisyphean problem is something like this. How can an enterprise devoted to looking inward, that is focused on individual subjectivity, contribute to making positive changes in the outside, that is society? An outside that both creates and reflects that which is inside, especially when that inside is inherently contradictory. Our particular impossible mission is to understand how the mental health profession in the United States is organized, who it serves, and what practitioners ought to do in the face of demands from outside and within the profession to streamline and trivialize the healing profession. If we live, as Christopher Lasch once put it, in the therapeutic society, just what kind of therapy are we giving and getting? I'd like to make one more contextual comment here. I personally consider psychoanalysis to be a subversive enterprise by its very nature. Naturally, it subverts itself, and it reacts to that subversion. And I'll give you two examples, okay? One is, though we talk about the interminable length of psychoanalysis, the founder of psychoanalysis in Chicago, who was brought here, as we mentioned last night, by Robert Hutchins, a man named Franz Alexander, who established the Chicago Institute and Chicago Psychoanalytic Society, tried to subvert psychoanalysis as usual and make it a quicker affair. So he proposed something called the corrective emotional experience. This did not go well with the prevailing community and led to a certain amount of conflict, which he reserved, like many Americans resolve conflict, that he moved to California. I'd like to bring up another psychoanalyst here that's a little more relevant to our discussion today. And it's interesting, like Franz Alexander, this was a Hungarian man. His name was Thomas Szasz. Thomas Szasz was one of the original cadre of psychoanalysts here. He worked at the Chicago Institute from 1951 to about 1960. And Szasz, following his own individual ideas, came to consider the entire mental health system that we're about to discuss today to be based on a myth. That is, the myth of mental illness, which he considered to be part of a sociological trend that he called medicalization. That is to say, a manner of explaining how medical knowledge is applied to behaviors that are not evidently medical or biological, and which he felt shaped the entire society and has had an impact on what we're up to today. So with this kind of preamble, I would like to introduce our panel en masse, and then we'll start off one by one. At my right is Allan Scholom. He is a clinical psychologist and psychoanalyst in private practice in Chicago, and he's the secretary of the board of the Chicago Center for Psychoanalysis and the chair of the Professional Affairs Committee there, and he's on the faculty of the Institute for Clinical Social Work and the founder and chair of the Illinois Coalition of Mental Health Professionals and Consumers. Next to him is Patrick Knight, and Patrick is a PhD candidate at the Department of Anthropology and at the University of Illinois in Chicago, where he serves as a lecturer. Patrick received his MA from the University of Illinois at Chicago and his BA from Xavier University. And next to him is Mark Heyrman, is that right? Heyrman, sorry. He's a clinical professor at the University of Chicago Law School who teaches courses in trial practice and mental health advocacy and mental health law. We are possibly going to be joined by Dr. Susan Scherer, who is a child psychiatrist in private practice in Chicago. So we're going to start out with Dr. Scholom and look forward to his presentation.
We all supposed to have 12 to 15 minutes, so we have to talk fast and speaking to him. And if I speak too fast, because I get kind of edgy to get everything in you want to say, which never happens anyway. But so please stop me if I'm talking too fast. I'm reading from a paper that I can send you a copy of. It's coming out this summer. It's a much larger paper, and I'm going to have to abridge it quite a bit. But I need to present some of the background because I want to talk on a sort of larger cultural, political level as well as the internal, and see if we can find an interface there, which I think is the challenge for psychoanalysis these days, to look at the context in which we operate. So the larger paper is called Challenging the System, American Fantasies, and Resistance to Real Reform. And it starts with the basic premises that has to do with economic inequality and the expanding economic inequality, and why people tolerate it, which is the basic question. Why we aren't in the streets rebelling against the system that's causing so much misery. There's a quote from Freud that I might start with, which it goes without saying that a civilization which leaves so large a number of its participants unsatisfied and drives them into revolt neither has nor deserves the prospect of a lasting existence. Okay, first I want to talk about what I consider to be the fantasies that contribute to people's oppression, that are deeply embedded in our culture. Okay, so the particular fantasies include that we live in the most democratic of societies, as opposed to one where the information and ideas necessary for a truer form of freedom are severely limited. That there is such a thing as a free market, as opposed to a system where those in power make the fundamental rules. That the two-party system represents a real choice, as opposed to a structure that seriously constricts challenge to the status quo and those who most benefit from it. That the private sector is inherently more efficient and effective than the public, as opposed to a view that recognizes that the market does not necessarily work optimally, if at all, as in healthcare. That there is such a thing as big or small government, as opposed to the reality that size, as in the number of people working in government, does not change with the party in power, but rather what matters is what government does with our resources, that is, whether policies favor corporations or benefit the public. That the American dream still exists, as opposed to the notion that it is illusion that places responsibility even blame on those who do not make it. That American exceptionalism is an expression of omnipotence used by those in power to exert power, and by those not in power to feel powerful via identification with the aggressor. And correspondingly, that we in the United States are beyond what happens in the rest of the world. And American individualism, as a way of disavowing context, history, and responsibility such that little matters except what can be done on one's own, leading to self-blame rather than to outward protest. Lastly, we'll consider the role of psychoanalysis as a force that can be of help in creating greater awareness of social reality, while mindful of Jung's observation that, quote, people can't stand too much reality. With that in mind, let me present some reality, because I have to present a bunch of numbers there to put the healthcare system in larger context, because this is part of what doesn't get, the story that doesn't get spoken of by the mainstream media, and hence we're at a loss as to how to analyze the system. Okay. So where does healthcare fit in the larger discussion? Healthcare is in the vanguard. As the biggest industry in the country, nearly $3 trillion was spent last year on healthcare, and a negative model where many are hurt and killed for the profit of a few. Nearly 45,000 Americans die every year for lack of health insurance. A lot of this data comes from the Physicians for a National Health Program, which is extraordinary group, but also it's a clearinghouse for terrific data on the healthcare situation in the country. Obamacare will leave tens of millions uninsured and scores of millions underinsured. In fact, in the last year or so, preparatory to the law, there have been a notable increase of several million people without insurance. So far, in the sort of preparatory sense, the insurance level of uninsurance is higher, and the level of underinsurance is higher. At the same time, virtually nothing will be done to control costs, with the consequence that we will pay more while getting less and less for it. When we talk about costs, we are speaking in relation to system costs. Administrative, many workers doing a great deal to make care harder to get, which has helped the unemployment rate, but keep it lower, but results in individuals having to spend much more for their health care. In other words, we could look at the level of employment in healthcare, which has been staggering over the last years in terms of the numbers of people working. But a lot of them are bureaucrats that work for health insurance companies. That this has kept the unemployment rate sort of artificially lower than it might be, while at the same time resulting in costs being passed on in terms of the aggregate cost of the healthcare system. Okay, so we have the administrative stuff. We have stockholder profits. We have the cost of advertising and marketing. We have the debt repayment from mergers and acquisitions. And, of course, the stuff you hear about in terms of executive compensation compared to the money spent. All this is compared to the money spent on actual delivery of care. A conservative figure of 31% for these, quote, system costs is often cited. This is in contrast to the cost of single-payer systems, typically less than 10%. Medicare actually costs about 3 to 4% to administer. So when you talk about the myth of the private sector as being more efficient, this is complete fantasy. Medicare is a far more efficient system in terms of the actual cost to administer and provide, and how many dollars go to service as opposed to the bureaucracy and all these other costs, the system costs, what I call them. Thus, we can see that the private health insurance industry is largely responsible for high costs and therefore fewer resources to spend. It is, in essence, an unnecessary middleman bleeding the citizenry. Next are the drug companies, whose prices are not controlled the way they are in other countries with single-payer systems. As a result, drugs cost about 1/3 to 1/2 more here than they do in other countries. Last year, there were over 4 billion prescriptions written, about 13 per person in the United States. Another important advantage of single-payer systems is that the competition and thereby duplication, all or most hospitals currently offering all or most services, is minimized, thus saving money. In healthcare, the market not only does not work, it is the problem. In other words, the fact of competition does not lower costs. It just adds to costs by having all these middlemen and duplication of services, which is why in the United States we spend about twice as much as most other countries with single-payer systems who deliver more for their citizenry. On a macro level, the clearer picture of the situation emerges when we consider the U.S. spent 17.4% of GDP on healthcare, in contrast to the 13 other developed countries with single-payer systems, which average 9.5%. This is almost double, while per capita spending was $7,960 versus $3,182. Far more than twice as much per capita as countries which deliver more services in terms of doctors' visits, hospital days, et cetera, and get better outcomes. Premiums have more than doubled over the last 10 years as out-of-pocket costs, all growing at a rate more than 3 times faster than inflation. Nevertheless, outcomes from life expectancy to infant mortality continue to deteriorate. This is not surprising given that we get fewer services at greater cost, including outpatient visits, hospital days, and surgeries, et cetera, per capita than those received in many single-payer systems around the world. There is a common myth that an aging population is one of the main drivers of healthcare escalation. This is absurd, as all developing countries have aging populations, even older than the United States, which has a lower life expectancy, and they spend less money. All right, so how can this be? How do we have this system? The most Direct explanation is that it is exactly the for-profit forces driving the corporate takeover of healthcare in the 1980s and 90s that are responsible. In other words, before the 80s, healthcare was basically a mom-and-pop operation. And when it became clearer to the capitalist class, to the large corporate entities, that money could be made, you might say there was a corporate takeover. And there's lots of data to indicate the consolidations of hospitals and so forth to support that. I have another paper, if you're interested, that talks about that. In reality, what we have is not so much a system, but rather a patchwork of largely corporatized exploitive profit centers. If our outcomes are far worse and our expenses are far greater, and if services we offer are at best on a par in aggregate, then what is left but the costs and profits of the system itself to blame? An associated myth is that employers pay the major share of health care costs. The actual number is 20%, with the government paying 60% through our taxes, and we pay out of pocket about the other 20%. And it's another whole fantasy that this is a private system with corporations paying all this money. It's absurd. We pay, in 2006, more than one-third of every tax dollar collected, about 1.2 out of $3.5 trillion at the federal, state, and local levels went to health care. For a family with a household income of $50,000, about the U.S. median, more than 25%, premiums plus taxes, goes for health care, with about 10%, over $5,000, spent through taxes alone for various government-funded programs. In effect, in the U.S., we are paying for a great deal more health care than we are getting, with a lot poorer outcomes. While we pay for universal coverage, we do not receive it. In contrast, all of the developed and much of the developing world have acknowledged that health care is a right, not a privilege of wealth. This is the only humane and economically viable solution. It is important to note that I want to begin to expand this to larger society in general, because we can talk about the system itself and the limitations of the system, which other panelists will, I'm sure, take up. But there's a larger connection I want to make between the economic system itself and healthcare outcomes. It is important to note that there is an injurious relationship between adverse societal conditions and healthcare. The influences of lifestyle, such as in stress, eating, and sleeping, socioeconomic, as in poverty, and environmental, as in exposure to toxins in what we eat and breathe, all negatively affect mental and physical health. Estimates of these forces reach into the 60 to 70% range. Simply put, Americans work more hours per year than any other industrialized country, 137 to be exact last year. Japan was second. We passed them about 5 years ago. We sleep less, about 6.7 hours now than we did a few years ago when we were sleeping over 7 hours a night. We have about 50 to 70 million people suffering from sleep disorders. We eat more. In 1962, the obesity rate was 13% for adults and has grown to 35.7% today. In 2010, the highest in the world, according to the CDC. Further, there were over 200 million prescriptions written for antidepressants last year, 70 million for anxiety, and more than 19 million for erectile dysfunction. We're having an epidemic of impotence among men. It's very interesting, that just to consider what that means in terms of the stresses and pressures on people, such that these kinds of things become necessitated. In an exhaustive study of the National Research Council and the Institute of Medicine, concluded that the citizens of the United States suffer poorer health than those of nearly every industrialized country in the world, 17 in total. We were at or near the bottom in most categories, including life expectancy for males, the lowest of all. Our situation has been deteriorating since the 1970s, with women particularly adversely affected. Quote, "We were stunned by the propensity of all of the findings, all on the negative side. The scope of the disadvantage covers all ages, both sexes, all classes of society," wrote the chair of the panel. This is a fairly sort of neutral panel, not particularly political. In analyzing the causes of the report, the indication, adverse economic conditions and social conditions were indicated, as well as public policies and social values. In sum, we can fairly conclude that the status quo is both harmful and deadly to our health, and getting worse. It is not surprising to find this in a society that is fundamentally organized around economic values and interests, which largely benefit the 1% or 1/10 of 1%, or however you want to draw the line, over the well-being of its citizens. Some call the current economic system corporate capitalism in view of the domination of these entities. Actually, it was Marx who named it capitalism in recognition of the power of capital and money. This surely was not what Adam Smith had in mind when he warned of the conspiracy of the masters, the merchants and manufacturers able to control state power for their own ends. Dwight Eisenhower warned of the military-industrial complex. Pope Benedict denounced the prevalence of selfish and individualistic mindset, which also finds expression in unregulated capitalism. We're running out of time? Okay. Well, I guess I'll have to stop here. Let me say one more thing about psychoanalysis in relation to all this. I think the role of analysis, which hopefully we can get back to in the question and answer, has to do with it being an approach to understanding and analyzing these sorts of cultural conditions. And we analyze patients, we analyze ourselves, and yet we get reluctant to look at the larger culture. Years ago, it probably had to do with the hegemony or the concern about having a role for ourselves in the culture, and in Freud's terms, there was a great fear that if you were too critical of the culture, this would be harmful in terms of the position that psychoanalysis might evolve into. I think today we've already become so marginalized, and part of the reason that we've become so marginalized is because of our failure to stand on the side of people and to offer a cultural critique that might empower those who need to know some of the things that they're being faced with. And I think this is what the psychoanalytic mission, in its most revolutionary sense, is all about, and what we ought to be doing these days in terms of analyzing the culture and offering that critique to the masses, as many people as we can reach. This has been done in France, it's done in Latin America, and maybe we can talk more about it later.
Okay, that's a good note to end on, because I hope you'll elaborate on the last point you're making about what it is that's led us to inhibit our own better impulses in terms of being able to tackle these social issues as a field and individually.
So everything is either about sex or money, and I'm from the law school, so we're going to talk about money. We're going to talk about who pays for health care, particularly mental health care, how it's paid for, and and also to talk about the connection between that and mental illness and mental health, because I think that's part of our confusion. What are we paying for when we're paying for health or illness? So there are some things ways in which the mental health system is just like the rest of the healthcare system, and there are ways in which it's different. We do have clearly a class system for paying for healthcare. So there are really just very few generic sources of funds for healthcare and for mental health care. One is Medicare. You pay into the system, you get old and you get disabled. We think of that as a healthcare system for the deserving poor, because you paid in, therefore you're deserving. We have Medicaid, which is for the undeserving poor. You didn't pay in, and therefore you get much less services. Think about what sense it makes. So we're going to talk about this. I'll talk about this more in a few minutes. These are two big government programs. They're two of the largest government programs of all, Medicare and Medicaid. And they pay for health care of all different kinds. They pay for 10 million different kinds of health care. The Medicaid rules are run on for thousands of pages, as do the Medicare rules. And of course, one of the things that if you're going to pay for any kind of health care, you have to figure out how much you're going to pay. How much you're going to pay. Whether it's for an ER visit, a visit with a psychiatrist, or a visit with any other healthcare professional. So explain to me what sense it makes for Medicaid to pay a different rate for services than Medicare. And is there any guess about which pays more? Medicare for the deserving poor, or Medicaid for the undeserving poor? Of course, Medicare pays way more than Medicaid in every single state for every single service. Period, end of story. We'll talk about how that affects mental health services in that. So Medicare is available for all of us who pay into the Social Security system. When we get to be old, we'll get it if it hasn't gone bankrupt. And if you become disabled before you get old, you can also get money from Medicare. And Medicaid is for people who haven't paid into the system and are poor and need government help in paying for their health care. And then, of course, we have private insurance and different ways of private insurance. And then, of course, we have people who are rich and can just pay out of pocket. That is the 1%. The number of people who pay out of pocket for everything is very small, but as was suggested, we all pay out of pocket for almost everything, a little bit. Now, those are the sources of payment for ordinary health care. Mental health care has a legacy system in most states, which started out with the fact that almost all mental health care was provided for in psychiatric hospitals. So if you were diagnosed with a serious mental illness, you went to a psychiatric hospital and you often spent the rest of your life there. And every single state ran state hospitals. We used to have 20 of them here in Illinois. We closed 2 of them last year. We now have 7. Illinois is, I do a lot of mental health advocacy, and I often say that we should change our license plate from Land of Lincoln to Thank God for Mississippi. But in fact, so that we aren't the worst state. But in fact, in Mississippi, they've changed their license plate to Thank God for Illinois. Because we are, in many regards, the worst state in terms of mental health services, government-funded mental health services. But there are ways in which we're just like every other state. So over the last 60 years, 95% of the state psychiatric hospital beds have closed. In Illinois, in the 1950s, when we hit our peak, we had 35,000 state psychiatric hospital beds. As of the closure of Tinley Park and Singer last year, we now have 1,200. Okay, 35,000 to 1,200. Okay, so what does that mean in the scheme of things? Well, that's during a period of time when the population of Illinois went from 7 million to 13 million. So if we just had the same number of beds per capita, we would have, instead of 1,200, we would have 70,000 or 60,000. Now, I'm not suggesting we need 60,000 or that we're ever going to go back there. We never are. But when we're no longer spending all that money on state psychiatric hospitals, what that has created is a legacy system in which the states also, many states also have a separate funding stream that is unconnected to Medicaid that pays for community mental health services as a way of dealing with the people who used to be in state psychiatric hospitals. That is used to be a substantial source of funding for mental health services in most states, including Illinois. That is the thing that has gotten squeezed. So you can imagine if you're a state in a financial crisis, almost all of them are. There are a few western states that have oil revenues or coal revenues that are rising, but the rest of the states have financial problems, and Illinois has huge financial problems. So what are they going to cut? They're going to cut things where they don't get a federal matching dollars. So the way Medicaid works is it's a federal state program, and if Illinois spends $1 on health care for a poor person, it gets at least 50 cents back from the federal government. It may get more under certain circumstances. Importantly, Obamacare gives the states for a period of time 100 cents on the dollar, then ratcheting back to 90 cents on the dollar as an incentive to get states to enroll in the voluntary expansion of Medicaid. It is likely that most of the states will eventually do that. Illinois is poised to do that in the next couple of weeks, to expand Medicaid to more poor people, that is, people who are less poor but still very, very poor. So those are the sources of funding: Medicaid, Medicare, private insurance, and then we have this legacy system of sort of direct government grants. Now, as I suspect almost everyone in the room knows, the how we pay has changed dramatically. So it used, and there is no way to pay for health care that makes sense. There just is no way to pay for health care that makes sense. And what you will have to strive for is a way to pay for health care that is not nonsense. And unfortunately, we're closer to nonsense than sense in most states and in Illinois. So the problem with fee-for-service, which is the traditional model for health care, is it provides no particular incentive for the provider to care about the costs. And if the costs are being borne by a third party, it provides no particular incentive for the patient to care about costs. So there are no cost controls. Now, the problems associated with fee-for-service have been exaggerated in many ways. They're exaggerated by the fact that, so people have said, well, if you don't have any disincentive, that people will just go and get excessive health care. Well, that's a little bit silly. How many of you, if you really just needed one leg amputated, you'd say, gee, it's free, I'll have two? There's very little interest in the public in getting excessive health care. The problem is there may be an interest among providers in providing excessive health care, and so from time to time we have scandals about that. Some of them are focused on Medicare and Medicaid, but they're just as much focused on private insurance. And as the previous speaker accurately said, Medicare is more efficient than private insurance, so is Medicaid. And by efficient, I mean how many of the dollars are going to actual health care as opposed to waste, fraud, abuse, administrative costs. The answer is Medicaid is the most efficient healthcare system in this country. Medicare is second, and then everything else is third in terms of how much of the money actually goes to healthcare, that is appropriate healthcare, not duplicative or wasteful healthcare, and doesn't go to some other administrative burden like paperwork, etc., of which we have tons. So what we have done and what we are continuing to do, as everyone knows, is move to some kind of managed care. Managed care is got, of course, its many advantages, and if you think about it in an idealized system, it's perfect. Unfortunately, there is no idealized system. So the idealized system is that if I'm the payer, if I'm some insurance company, or I'm the ultimately responsible person who will have to pay all the costs, will figure out that I should give people preventive care and other kinds of care to avoid more expensive costs later. The problem with that is multiple, but the first big problem is that only works if you really have a responsibility over an extended period of time, preferably a lifetime, and you have responsibility in a way in which you can't pick and choose which patients you want to take care of. And so what we have found where we have competition among managed care entities is that managed care entities are competing for the patients who are less apt to be costly. And we don't have any understanding, managed care entities understand that this is not a lifetime commitment. So that if you do have, I mean, this is the reason why single-payer systems in other countries can be, and often are, way more efficient than our system, which is that if you're the French government, which is widely considered to have the most cost-effective healthcare system, you understand that you can't go out of business and ship all your citizens to Germany, unlike an insurance company. You're stuck with them forever. They're always going to be your citizens. And so if you spend money today, you can decide within the limits of knowledge, there are limits of knowledge, you can decide whether or not that money is being well spent on prevention or foolishly spent on prevention. Is it better to provide more services for people who are less sick now to avoid expenses for people who are more sick later? And presumably you at least have the right incentives to do that. But if you can get out of the business or simply say, well, it's no longer cost effective for me to run managed care in Illinois, I'll move to Ohio, you see, you're not really in it for the long haul. In mental health, we have, I'll now reveal to you, yet another important source of payment, an important place where we can dump people with mental illness. So what is the largest single provider of mental health services in a single site in Illinois? Yes, the Cook County Jail, and no one else is close. There are at least 1,800 people at any given moment who are on psychotropic medications at our jail. Okay, that's 1,800 people. Remember that all 7 state psychiatric hospitals have 1,200 people. Okay, there are 6,000 people with serious mental illnesses in our state prison system. That's larger than the number of all the public and private psychiatric hospital beds in the state. Okay? So there's about 4,200 public and private psychiatric hospital beds in Illinois, 6,000 people at any moment in our state prison system. So one of the things that annoying and obnoxious mental health advocates like me say when the state says they're going to move Medicaid recipients to managed care for their mental health services, I say, well, make them fully at risk. Oh, we are. He said, so when someone with a serious mental illness ends up in the jail, Aetna Better Health will have to pay for their health care in the jail and the cost of keeping them. Oh, no, that's not a health care problem. That's a criminal justice problem. But no, it's a health care problem. And in fact, while it's important not to stigmatize people with mental illnesses, they in fact commit fewer crimes than people without mental illnesses. There are huge numbers of people who have committed low-level crimes who end up in the criminal justice system, and that is tied directly to our failure to provide community mental health services and other decent mental health services to them. Now, the next question that I'll address, and my time I think is
2 minutes.
Pretty much over.
Yep.
Is so the way the healthcare system is focused. I agree with Zaz on only one thing he ever said. I disagree with him about everything else. The mental health system is excessively medicalized, and has been, and that's because what is the name of Medicare? MED. It starts with an MED. Medicine. What is the name of Medicaid? It's MED. And so we approach all mental health problems from a medical perspective, which is often quite useful. That is, we have appropriate treatments that are quite useful for people with very serious mental illnesses, schizophrenia, bipolar disorder, lots of illnesses that are effectively treated with medications. However, what we have learned is that lots of other kinds of services, including psychotherapy, of course, but lots of other types of services are as effective or more effective than the typical medical services. So the two, and the nice thing is at least the federal government is beginning to recognize this. The Substance Abuse and Mental Health Services Administration, which is our federal, one of our two important federal mental health agencies, keeps now a database of evidence-based practices. And what are the two best evidence-based practices for people with serious mental illnesses? Supportive housing and supportive employment. Give people a safe place to live and help them stay in a job. And I'm talking about people with very serious mental illnesses, schizophrenia and bipolar disorder. Those are the two most effective treatments. And of course, it's hard to convince an insurance company to pay for housing or help with a job. So the good news, there actually is good news in the health system, is that as we have created models for managed care, we have also recognized that it is cost effective to spend money on these social services. And notice that while you can easily see why this works for someone with a mental illness, this is another of the serious structural problems with our health care that differentiates us from, I'll again pick out France. What's the difference between, one of the major differences between healthcare in France and healthcare, and I'm not talking about mental healthcare in France and healthcare here, is they provide a whole heck of a lot of social services for people when they leave a hospital. We don't do that. We don't follow up. So let me just finish up. The other big problem, it seems to me, is are we going to focus on mental illness or mental health? I frankly see no near-term and perhaps far-term idea that to the extent we're focused on mental illness, we will pay for analysis. But I have a ray of hope. And that is that employers have recognized the idea of wellness. And so they will, my employer, the University of Chicago, will actually pay if you go to a healthcare clinic. You see, why are they doing that? It's prevention. And it seems to me that if you start thinking about prevention and mental wellness and productivity, you can then see a role for psychoanalysis in that goal of allowing people to live, to be more fulfilled, and therefore to be more apt to be happy and productive employees. I've overstayed my time.
Done fine. Thank you. One thing I think that really comes through in our first two discussions is the conviction and passion that they have. And I think one psychoanalytic type comment that I'll make is once you have conviction, that's fine. Where does the unconscious then fit in terms of how we as individuals can take that conviction and translate it to convince somebody else? And how do we address the unconscious of other people in such a way that they can be receptive to influence? And of course, on an individual basis within psychoanalysis, this is an issue that occurs between patient and therapist as well. Issues of relationship, alliance, and persuasion. These are very fundamental issues. So Mr. Knight, if you would now add your comments.
Of course, I'm delighted to be here to share some thoughts about this subject. I would like to thank, of course, the Society for Psychoanalytic Inquiry, Jeremy, our panelists here, which I thoroughly enjoyed hearing from, as well as the attendees and Dylan Lott and Andrew Cousins. So thank you all. My talk today concerns a small-scale residential mental health treatment program in Chicago called Hemsworth. I'll start by discussing Hemsworth and the kind of treatment that is provided at this health setting. Next, I consider what Hemsworth reveals about recovery, this model of care said to revolutionize the mental health system. I then conclude with some meditations on what this all means for the subject. My main contention in this talk is that recovery, as practice, functions primarily within and as a university discourse, which has predictable consequences for the subject. Regrettably, I will not have time to get to the 388, which is a program in Quebec City, which I wanted to talk about, but I had to hack away at this. As a prefatory note, the data I drawn for this talk stems from anthropological fieldwork. I performed at 2 mental health programs in the Chicagoland area, where I also work as a part-time staff member. For this talk, I aim to balance theoretical points with ethnographic data. Speaking of the latter, I would like to start with a brief excerpt from my field notes. Here I'm interviewing Devin, a consumer at Hemsworth. He starts, "If you saw me on the street, you knew I was no good," Devin said, with eyebrows slightly raised and eyes now widened. His statement came in the middle of our interview in his apartment on one of those 2 sticky Chicago summer afternoons. We sat in his living room with a half-working AC unit humming in the background. He smoked and occasionally glanced at a little white TV displaying an old Western show while I waited for his next statement. After a slight pause, Devin leaned forward, rested his cigarette in the ashtray, and continued. "There was a long time when I was addicted to alcohol. If you gave me 15 cents, I would ask for 30. He goes on. "I used to be a little hooligan on the streets. I asked him to repeat. A hooligan? He says the word again, hooligan. Perhaps a cross between a hooligan and a ruffian, I think, since he describes it as someone who did no good. But I have changed," he now says in a serious tone. "The people here really help you. I was crawling when I came here, but I am walking tall. They give me good advice here." For the last 5 years, Devin has been a consumer at a mental health program in Chicago known as a community integrated living arrangement. I would use the term, the much simpler term, SILA in this talk to refer to these programs. The first SILAs in Illinois were designed by the Illinois Department of Human Services in 1989 in response to the provisions of the Omnibus Budget Reconciliation Act of 1987, which demanded programmatic solutions to trans-institutionalization. That is, the collection of individuals in nursing homes after being released from hospitals. To paraphrase Jerry Florish, SILs have the general goal of producing money-managing, well-mannered, independent, apartment-dwelling consumers. It aims to achieve this goal by providing what is called recovery-oriented care. SILs operate 24 hours a day throughout the year. They are small-scale, no more than 8 consumers at one time, and rely on a community support team to provide services. Hemsworth becomes a SIL in the early 1990s. The program itself is located in a large 3-flat building just off a busy street in a predominantly African-American neighborhood in Chicago. The outside of the building blends with the surrounding environment. No signs mark it as a SIL or a mental health program, and one could easily walk by it without noticing how the space was used. Within the building, on the main floor, is the Hemsworth office. This is where consumers come down to meet staff for treatment. Apartments for SILA consumers are on the 2nd floor, directly above, again, it's a residential setting. And on the 3rd floor, residents from the community reside. During main operational hours, there's a constant stream of people entering and exiting the building, as well as moving from different floors for office visits, laundry, and mail pickups. Throughout the week, consumers run errands, visiting many of the small businesses nearby, and attend a steady flow of appointments with doctors, therapists, SILA staff, and improved facilitators. Staff at Hemsworth provide a range of community support services to consumers. Upon entering the program, case managers would begin efforts to link consumers with SSDI, clinical services, a psychiatrist, transportation, an apartment, grocery stores, and other resources. During this process, a number of documents were generated to guide practice. There was a mental health assessment, a revision, a crisis plan, a locus evaluation, a person-centered treatment plan. These were all created from face-to-face meetings. Staff would draw on treatment plans when preparing for consumer sessions. These meetings, which occurred during the main operational hours of the program, roughly 8 a.m. to 8 p.m., and were an hour long, focused on teaching consumers a range of daily living skills, coping strategies, meal planning, illness insight, and more. Although staff occasionally did other office work, most of their shift was spent planning, performing, and writing up one-on-one sessions with consumers. Sessions with consumers and staff often took on a teacher-pupil relationship. Interestingly, rarely ever were consumers told to do something directly because a staff member said so. Rather, there was a strategic use of or reference to documents, either in the case of mentioning that something will be documented, as when a consumer recognizes that his apartment is messy but doesn't feel like cleaning it, or during scheduled sessions where documents containing the latest information on a diagnosis, a coping strategy, or a dietary trend were printed, shared, and referenced. As an example of this will be documented strategy, I came across the following staff log entry one day. To quote, MHP asked Rachel, was she coming back down for group, and she said no. When asked why, she wouldn't answer. MHP explained to her that it would be documented, that she refuses to come to group. Rachel responded, it doesn't matter, laughed and walked away. The development of a pedagogical social bond is also encouraged in the language of progress notes. Although the terms coached, taught, educated, demonstrated, prompted, and instructed are not new to the field of community mental health, and indeed all part of all psychotherapies. At Hemsworth, they became the guiding light for staff's daily recovery-oriented interventions with consumers. For example, Arnold, a staff member, has a shift from 8 a.m. to 4 p.m. on Mondays. From 8:30 to 9:30 a.m., he meets with Leonard, a consumer, to give him, quote, weekly allowance and teach him effective strategies for budget management. Next, Arnold meets with Steve, another consumer, from 9:30 to 10:30 a.m. to educate him on affordable housing in the community. Steve is getting ready to graduate, which is a term that surfaces in Hemsworth quite a bit, from the program since he has completed most goals on his treatment plan. This phrase, I take my medications upstairs now, was a phrase I heard often from consumers while I work a Saturday shift. And it's my contention here that one of the overarching goals of Hemsworth is to produce medication-compliant consumers. Indeed, graduating from the program was contingent upon demonstrating knowledge of one's meds and the ability to take them independent of staff reminders. Consumers achieve this by making regular visits to the office to take prescribed medications and fill pill containers. While sitting at a table at the center of the office, staff would often quiz consumers on different facets of the medication, names of meds, the dosage, whether they're taking it for, the likely to be side effects, when to request refills, and so on. Once a consumer reported regularly for medication and recited the facts about each drug, the weekly pill container would be kept up in one's apartment. Consumers then would be expected to call down the staff and inform them that meds were taken, ingested. Few will be surprised to hear that the industrial pharmaceutical complex and biopsychiatry were at full swing at Hemsworth. The program is, after all, a part of a broader organization that makes its interest in biochemical interventions, neurobiology, and business innovation well known. This program emphasis inevitably surfaced in consumer narratives. During my first time in a community support group, one consumer said after stating his name that, to quote, the chemicals in my brain are off, do you think vitamins would help? End quote. If psychiatric knowledge was not already part of one's presentation of self, consumers was soon educated on it during illness insight sessions. What was moderately surprising at Hemsworth was the amount of program time and effort invested in monitoring both the use and effects of medication. For example, Yolanda's impending med change was reason for a brief office celebration one staff meeting. A staff member said that this was a good thing, to quote, since Yolanda, and again to paraphrase, has been sterner with staff and peers lately and has begun talking about the Army officer in the attic, again, and paraphrase. Additionally, the first piece of information documented for consumer in the staff log was whether or not meds were taken. Although the recovery model largely suppresses talk of pathology and deficit, the disciplinary power of biopsychiatry is nonetheless reaffirmed in that they practice and talk with staff. So what does this overview of treatment at Hemsworth reveal about recovery, this model that is the buzz, I guess you could say, of a mental health system? Using the concept of discourse, I would argue that recovery, as it is practiced, which is an important distinction, functions within and primarily as a universe of discourse. While I don't have the time to survey the nuances of the university discourse, suffice it to recall that for this math theme, knowledge occupies the position of agent, object A or little a is in the position of object, divided subject stands as the product, and master signifiers are in the place of truth. So how does recovery function within the university discourse? Recovery in the U.S. begins as a diverse movement inspired by a wealth of cultural events, World Health Organization studies, anti-psychiatry discourse, and more. Over time, however, recovery was congealed into a more or less stable set of principles, still debated, of course, ready for programs to sell to consumers. Although, again, I recognize that excitation survivors are part of this kind of debate and discourse as well, but at Hemsworth, it was always consumer, even by staff and by recipients of care. There are two developments in this congealing process that allow us to identify how recovery operates within a university discourse. The first and perhaps predictable development is that recovery movement was appropriated and hence domesticated by the pervasive bureaucracy of late capitalism. At the beginning of the recovery movement, there was a pressing rawness to the protests. Those being mad in society stood as reminders from the health system that had failed, and that radical change was the only direction forward. With time, this mostly amorphous group protesting the mental health system was assigned a signifier, consumers, a peculiar economic label for persons grappling with illness. And their demands became subsumed under what is now known as recovery-oriented care. Care, once again, to be sold to consumers. Interestingly, at Hemsworth, I was told by staff to quote, that recovery wasn't something they did until the program transitioned to a fee-for-service, end quote. That is, recovery arrives once a proper payment system is in place. Even more recently, at the start of this year, staff at Hemsworth began attending an agency-wide training focused on, as I was told somewhat excitedly by one supervisor, to quote, identifying where the weights are and how to make things more efficient. He went on to talk about the many uses of flowcharts. The second development is that recovery was brought more in line with hegemonic biomedicine, particularly biological psychiatry. Presidential declarations of the brain decade, official commissions that call for more science in psychopharmacology when diagnosing and treating, the recent NIMH snubbing of the new DSM in favor for what it deems more valid biochemical markers of mental illness, and so on, ensures that biomedicine remains doxa. Recovery care does not threaten this doxa. Consumers are handed diagnoses, taught the realities of the brain disease, and educated on how they should speak and understand themselves. All the while, consumers are said to be the experts of their care and in charge of reforming the system. Even at Hemsworth, recovery care was provided only to the extent that it was seen as medically necessary, which is a huge buzz that I hear relentlessly at Hemsworth, and thus in compliance with evidence-based practices. In this brief overview, both contemporary bureaucracy and biomedicine are viewed as exemplars of the university discourse and are considered to have ensnared recovery. Next, I argue that recovery as practice functions as a university discourse. As I have discussed earlier via Hemsworth, psychopedagogy is recovery's main mode of operation. The MHP agent, representing a supposedly neutral knowledge, addresses the other, the subject as consumer, who must be emptied of any knowledge that interferes with receiving the message. However, something skips this totalizing function of this truth system, a remainder persists. In other words, objectification is incomplete, hence the little a in the position of the other. The product of this activity, not to enter the latent level of the discourse, is a divided subject. This lower level is marked by impotence since the product is never desired by the element in the position of truth. Indeed, desire here is necessarily disavowed, since admitting it would betray the pretense of neutrality. The subject here is both alienated by continually expanding symbolic knowledge that supersedes personal power, and exploited since it becomes a duty, in a sense, to nourish the system with one's activity. So what can be said more about this positioning of the subject here? At Hemsworth, a consumer's status as a mentally ill subject is solidified shortly after entering the program through a series of assessments, med training, psychiatrist appointments, and more. These activities enhance the consumer's ability to obtain SSDI and other public entitlements, but also position them almost exclusively as an object, namely as a victim of an organic agent. Illness experiences not explained by way of biomedical reference to brain disorder are covered through a psychological framework that fingers environmental experiences, rough upbringing, abuse, and so on, as the culpable agents. In either case, the responsibility resides in external agents. As Paul Verhagen asserts, the consequence of this positioning is that the subject is exonerated from any responsibility and infantilized, since the subject becomes best cared for in the hands of others. Even more, there's little room to resist here. Who would be against recovery, and why? Recovery is about the empowerment and pitching that it's all about the consumer leading the way. To return to the field note of that excerpt that started my talk, I was told by a staff member one day that Devon's next move is to a higher level of care. a nursing home, end quote. While this appears due in part to his age, it also appears to be partially a consequence of years of being positioned as an object of care. I wonder what could have been possible for Devin if he was not just a recipient of someone's good advice. To conclude, by drawing on the Kingian discourse theory, a rich resource for cultural critique, I would argue, and ethnographic data, it has been my aim to illustrate how recovery care in practice functions within and as a university discourse. This discourse, through the social bounds of the genders and so on, has consequences for the subject, namely its exclusion. Importantly, my critique is not intended to suggest that recovery is the same master discourse of the past, where confinement and torture were part of the scene. Recovery, even when it functions as a university discourse, is an improvement, albeit one that still evades and elides the subject. Lastly, as for reform the mental health care system, after exposing the work of master signifiers that underlie recovery and constitute its truth, the next step, I would argue, involves creating a language or model outside the compliance and education focus of mainstream recovery care. This is where 388 comes into play, since it is a program that encourages us to reimagine what is emancipatory for the subject, what is healing, what is revolutionary for the system, and so on. Unfortunately, I was not unable to get to 388, but thank you.
Thank you very much. So are we consumers? Are we clients? Are we patients? It's all very confusing, isn't it? When we start thinking about the language. Yeah. Okay, so now I'd like to introduce Dr. Susan Scherer, who is a pediatric and general psychiatrist and a graduate of U of C Pritzker School of Medicine and the UIC General Psychiatry Residency and Child and Adolescent Psychiatry Fellowship. She's a past president of the Illinois Council for Child and Adolescent Psychiatry and a member of Physicians for a National Health Program, and an advocate for legislation to improve mental health services for children and families across the state and nation.
Thank you. Did you want to say anything about a turkey?
About a turkey? You can tell a turkey story if you want.
That's later. I'd rather hear the 388 story.
Yeah.
I'm Susan Scherer. I'm a psychiatrist primarily treating children. And I hope you will all write down your comments and questions for these other speakers before you forget them, because that I would forget if I didn't write them down. So I want to apologize for coming in late, and I'm sure that we could spend a few hours analyzing that, but please, especially regret missing the first talk, and I hope I will be able to hear the recording of it. So anyway, I'm going to cut this kind of short because I wrote something which when I practiced it sounded like, kind of a machine gun with statements that were all in the same structure. So then I redid it with, it was going to be extemporaneous, and when I practiced that, I just got totally confused. So I'm just going to make a couple of initial comments that I don't want to forget. One is, child psychiatry is a wonderful field. It's fascinating, it's fun, it's very diverse. You can do so many things with it. And you are able to do things where you can tell that you've made a difference and helped somebody, a child or their family. So I would really encourage that. And I myself was a student in this room. I had lectures by, I forgot his first, Leon Cass. Was that it? Leon Cass spoke in here about medical ethics. And anyway, so I'm familiar with the room, and had 2 graduations down the street there. And I got married in Bond Chapel. Okay, so that's a little trivia about me. All right, so besides the fact that it's a great career, and that you should write down your questions and comments for the other speakers before you forget them, I'm going to say that I want to respond to what you were saying, and I want to take credit for getting Mark Heyrman here. That's my claim to fame. All right, so following on that, you said that Medicaid is the ideal system, and I'm going to give you a particular example of that in my work. Children who have Medicaid have a special privilege, which is that if they have a psychiatric emergency, which may occur at school or at home or on the playground or wherever, any citizen can call a hotline. It's called the CARES hotline. It stands for I forgot what it stands for, but anyway, there's a central dispatcher in Springfield who will contact the local SAS agency, and SAS stands for Screening and Assessment and some kind of service. I'm sorry. I just can't remember that either. But anyway, they send a social worker, for example, to the school. Let's say the child stabs another child with a pencil and says, I'm going to kill myself. Well, this happens every day. So a social worker comes from the local community mental health center where there is a staff of social workers who do this, and they go out to the location, usually within a couple of hours, and they talk to the child, they talk to the people who were there who thought that this was an emergency, and they will kind of make a judgment. It's as if it were like a mobile emergency room. This actually prevents them from having to go to the emergency room. And make an assessment as to whether they really ought to go to the emergency room or be hospitalized, or whether they can go home and receive outpatient therapy. Well, in either case, they qualify now for 90 days of intensive outpatient services from that same agency. So let's say it's C4. C4 is an agency in the West Side that stands for
Community Counseling Centers of Chicago.
Thank you. Okay, so then let's say the child doesn't need to, his common sense says, I'm not going to kill myself. Okay, but the person deserved to be stabbed or whatever. So then a social worker will typically go to the home. Used to be several times a week. Now I think it's at least once or twice a month. And talk to the child, talk to the parent, see how things are going, see if they can make any recommendations about behavior management. Sometimes they will do their meetings at school if there's a problem about finding a kid at home. Sometimes you show up at the home and you're not there. So oftentimes these services are at the school. They also will link them with theoretically they link them with a child psychiatrist to do an assessment and see if there's an indication for medication. Then over the course of the 90 days, ideally, the family will be linked with either that agency or another agency that can provide ongoing care. Now, too often the clinics that used to provide the ongoing care are not there anymore, and the waiting list at the universities is too long, so they don't get anything. And so the 90 days go by, and then another crisis happens, and then they get another round of 90 days of SAS services. But anyway, I think that it's wonderful that children can access immediate care this way, and that it's built into the Medicaid system, and it's a proactive. What's the word? It's a conservative measure, because if they don't need to be hospitalized, then they avoid that. If they do need to be hospitalized, then that social worker who came will call all the different hospitals or get them to the hospital and get them assessed so that they know before they go around in an ambulance from one place to the next that there's going to be a bed available someplace. All right, just a little bit more on that. It's true, all the psychiatric hospitals, many of the state hospitals have been closed. And all of the child and adolescent psychiatric beds were closed around 95. And so that service was transferred over, contracted with some of the private hospitals. And there are a couple of freestanding private psychiatric hospitals that kind of have a reputation for being open to accepting Medicaid patients. And so that's where these kids go. The other private hospitals, like the university hospitals, will accept some Medicaid, but they have a quota or there's a limit. And that's also true for outpatient services. So anyway, now I'm going to just make a point about what I think are some broad concerns. There's a shortage of mental health services for everyone. There's a particular shortage of mental health services for children, and that's partly because of a workforce shortage. There are not enough people doing that care at any level, as physicians or as psychologists, social workers, licensed clinical therapists. And my organization, I'm with the, I just got this, I'm with the American Academy of Child and Adolescent Psychiatry. And if you go to the website, www.aacap.org, you can find out all about how to become a child psychiatrist. Anyway, so we're advocating for some legislation that will create incentives for people to join mental health services at any level, and also to join, to train in the pediatric subspecialties, including child psychiatry. And one incentive in particular would be if they could have some help with loan repayment. That's another story that I won't go into because, medical students rack up a debt between $150,000 and $200,000, and they don't want to go for an extended period of training, which you'd have to do if you wanted to do child psychiatry, because that delays when they're going to start being able to pay back their loans, and it doesn't get you any greater income when you do. All right, so I think the wave of the future is going to be expansion of, or contraction of, well anyway, change in who does the work. So it's what we call scope of practice. Is that a well-known term or not? I don't know. Here's a scope of practice issue. There's a movement among psychologists to get licensed to prescribe medication. So that's already occurring in Louisiana and in New Mexico and in some military hospitals. And there's a movement in Illinois and many other states for that to be, for psychologists to get licensed. And they would do that by taking a course in psychopharmacology. But already there are people, very well qualified and wonderful, honorable people who do good work providing psychiatric care, who are nurse practitioners and physician assistants. They do have a biomedical background, so that kind of makes more sense for them to be prescribing, whereas I think that legislators get confused because psychology and psychiatry both start with psych. So, I talked to one woman in Springfield who, this bill comes up every year. So some years ago, the woman who was sponsoring it at that time met with me and some other people and said, well, she has a friend who goes to a psychologist, and the psychologist spends 55 minutes with her, but the psychiatrist only spends 10 minutes with her. So it seemed obvious to her that the psychologist should be the one to prescribe the medication. Because, she spends more time and knows her better. Well, we explained that it would make more sense for, somebody like a nurse or a physician assistant or a pediatrician or an internist or a, even a dentist or a veterinarian or a pharmacist. Then, anyway, so, but the scope of practice it's coming, and I think there will be, midwives who are serving the role of obstetricians, and there will be optometrists who take out cataracts instead of ophthalmologists, and in other ways. There will be people providing services that used to be provided by physicians, because there are not going to be enough physicians in the pipeline for primary care or any of the specialties. The pipeline is kind of drying up. So that means that we need to do more prevention on the one hand, and more, find other models, other ways of meeting the needs. And prevention is going to require research. There needs to be more research, especially in children's psychopharmacology, because drug companies have no motivation to study the effects of medications on children, because they can study them on adults, and there's less liability for them. It's not as hard to get subjects. You know, you have to jump through a lot more hoops to get children to be your subjects, both in terms of institutional review as well as, you know, parents' agreement to a double-blind study. So drug companies will market a drug for an adult, and then child psychiatrists and pediatricians extrapolate from those findings and, you know, make an empirical judgment what they think is going to hopefully be better than the way things are. And, you know, we rely on personal experience, other people's experience with adults. And anyway, so there needs to be more research specifically on the effects of, you know, efficacy and safety of medication for kids. And it needs to be publicly funded because of the problem with the conflict of interest.
Thank you, Susan. I think we have to stop now.
Okay.
Before we open up to questions, I'd just like to make one sort of summary comment and then let our panelists respond to each other as well. First, I wanted to second your encouragement for people to become child psychiatrists or any kind of mental health work. I know we're talking about this as being a Sisyphusian issue, but I think that, and I can speak to this also, before I came here this morning, I had a session with a boy I've been treating for years, a 16-year-old fellow who I've treated since he was like 9, something like that. I can't tell you how gratifying an experience this is and the kind of help that is available mental health-wise. Now, we haven't demonstrated this. This is part of the problem, is that there's not a way to demonstrate this so well, and it's a conviction that many of us have and that we have obtained through our experience on one side of the couch or the chair or the other. However, what I think is implicit here also is the pain involved in terms of the frustration in dealing with the system. And going back to what you were saying about public aid and the compliment, if there's a way of turning a sow's ear into a silk purse, the idea that that's one of the benefits that accrue from public aid, I think only underscores the fact that, as Mr. Heyrman was saying, public aid pays lousy. And so the University of Chicago, for example, which was developed by John D. Rockefeller and which he called the greatest investment he ever made, their hospital doesn't take public aid. None of the hospitals take public aid, and in fact, all the clinics that take public aid have been shut down. So it creates the devastating situation in which we know that there's so many ways we can help and nobody wants to pay for it. And I think in a nutshell, this is really one of the great difficulties and anguishes of being in the mental health field right now. And that'll be my final comment on this, but I'd like to now allow for our panelists to ask of themselves anything that they would like to inquire about.
Well, I'll just pick up on the thread that we just raised about payment.
We can't talk into the mic.
Oh, great.
Thank you.
You know, there's two ways in which I think we need to think about these issues. One is what we do now to address the problems that face us, whether in the clinics or practices or hospitals or whatever. And of course, funding becomes important, but we also have to think of the bigger picture and knock over. The bigger picture in terms of what are the systemic forces that generate these problems. You know, we're all talking about the failure of funding or the lack of money. We spend $3 trillion in this country on healthcare. It isn't a lack of money. We spend twice as much as any other country, and we get less. It isn't for lack of money. It's where the money goes. And the reason I wanted to present some of those numbers is because people usually don't get them from the mainstream media. We don't understand exactly the extent of the victimization and the exploitation that goes on here, and why the money doesn't go where it should be going in terms of the services that people need. While at the same time being aware of the larger picture that the system itself, I think, is creating a very sick population, whether we look at the hours worked, the stress-related conditions, the obesity rates, et cetera, et cetera. We have a systemic problem that needs also to be addressed in a larger sense. Part of the role of psychoanalysis, I think, is in the realm of critique. You know, Joe Colville once talked about the essence of psychoanalysis as critique, that we are, from a certain position of looking at phenomena, mostly individuals, but I think in a larger sense we could look at the culture to see where the problems are and to begin to understand and to educate and illuminate as to the unconscious cultural forces, you might say, the forces that work toward consolidating power, consolidating wealth, and exploitation of everybody else, the 99%, 1% divide, however we want to break that up. And to begin to analyze things and educate people who need to know the things that are being done to them. I think part of why I talk about fantasies is that when we don't have reality, we resort to fantasy that keeps us going. So we continue to believe that somehow the system really is working, despite the evidence that the system really doesn't work. And that part of our role in the analytic world, I think, is to educate, consciousness raise, call it what we will, to make the unconscious conscious, to make that which is out of our awareness more prominent. And that's the role I think we have to play going forward to first of all, amongst ourselves, because we in the analytic world are as guilty as anybody so far as isolating ourselves from the cultural mainstream, particularly in the United States, versus in other cultures, for instance in Latin America, where analysts were very prominent in the social movements and become aligned with the broader cultural forces and trends toward human emancipation and the overthrow of the dominant sort of oppressive governments and economic systems. In France also, the analysts have played a prominent role politically. But in the United States, it's been quite the opposite, where we've marginalized them ourselves, in part, well, for a whole lot of political reasons. But I will defer to some other comments for the moment. Let's see. Yeah. Anybody else? Mr. Heyrman.
Patrick, I love what your description of the co-optation of the recovery movement. It's worth sort of putting that in a little larger context. So the recovery movement really came from people who call themselves psychiatric survivors and the anti-psychiatry movement. That's where it came from. And as I said to all my friends, I knew the recovery movement was over when on the letterhead of the Department of Human Services, which runs our 9-state, but now 7-state psychiatric hospitals, it says recovery is our mission. That was the end of the recovery movement. And of course, how recovery is used by the Department of Human Services, and I deal with these bureaucrats every day, and they make no bones about it. They say, well, so I had a client who is seriously mentally ill in a jail, and didn't want mental health services that would have gotten him out of the jail, okay? And so that would have cost the state an arm and a leg to provide those mental health services. And so they said, well, we're respecting his wishes, we'll leave him in the jail. And let's just say mentally ill people, I've spent my whole life representing people with mental illnesses. I only represent people with mental illnesses. If you're not mentally ill, you cannot become my client. And you're volunteering.
Just kidding.
So I care deeply about the autonomy of people with mental illnesses, but not everyone with a mental illness has autonomy. And if you are mentally ill and you're in a jail and you think that's good for you, we need to appoint a guardian for you and have someone else make decisions until you get better. Because mentally ill, people with mental illnesses are just victims in prisons and jails. That's what happens to them. They become victims of the real criminals. And so the recovery is used as a slogan to say, okay, recovery, you've recovered, we'll not offer you a nickel more. And yes, you can say I want A, B, C, D in my recovery plan, but we only offer X and Y, and so, gee, I'm so sorry. And so that's the exact opposite of what recovery is about, which is about allowing persons, whether we call them consumers or not, to define their own goals first, not just will I be stable on medication the rest of my life, but could I lead a normal life, have friends, have a safe place to live, and then the ways of getting there. And of course, bureaucracies don't do well with people defining their own goals or their own ways of getting there. They say we have A, B, and C services, and if you want some of them, we're happy to give them to you within the limits of our money.
Yeah, obviously one of the questions that I'm mulling over is, so is recovery a revolution, and in what sense do you mean revolution? And then, in many ways, it functions as a brilliant kind of financial strategy. Of course, we want people to recover and kind of get off the system because that ultimately saves us money, even if that means kind of not really providing continuation of care and all these other things that say, wholesome services where people can really get help. So yeah, I appreciate your comments. It's really helpful. It's a question that's been bothering me because it has this really humanistic kind of, and it's well intended in these abstract principles, but I think that's my concern. How is this actually unfolding? And this whole idea of recovery is our mission, and the expectation is recovering all these injunctions. Speaks to a certain violence or a certain surreptitious kind of thread there. So thank you.
Can we open it up to audience questions then at this point? You've been very patient, and thank you for listening. Yes?
Well, I've been in this system since 1965, and I would say that, I saw the disintegration of the system. I would say it's all about money. And I would say that it's important to understand what I think Allan's trying to get at, which is fundamentally the zeitgeist. That what we have now, starting maybe 30, 35 years ago, is, look, if you just get rich or drop dead, nothing else is important. And we all, not we, I actually never bought it. And I never made much money. So I paid the price. I was there in the 70s when they started closing the hospitals, deinstitutionalizing it, they called it. Actually, and then they called it local control, which meant that the federal government was no longer returning money to the states that the states had given them, which meant that the states then had to pay double taxes to the federal government and care. They sent these people out of the hospital, supposedly for care. There were no social services. That's why you have Lakeview. That's why you have psychotic people on the buses, on the streets. And it started then. And there are no more mental health centers in the city. The reason why people don't go into the field is because there are no jobs. Because nobody's going to pay them to work. And managed care is no good because it's all about profit. It destroyed my field. I was a clinical social worker and in private practice, and I watched them make money off of everybody. It was disgusting. Now it became psychotherapy for the rich, and that's it. So, it's not hard to see what actually happened. So it's all about money, it's all about politics, it's all about what's important. No longer is it important quality of life, no more is it important about being a human being, about why is it good to be alive. It's just about money, and it's important. And I think that we have something to say about how this has affected all of our ability to actually criticize and object to what is going on now. That people are kind of passive and kind of like, well, what can you do? You can't fight City Hall. It has infected us. So that's what I have to say.
I want to speak to that a little bit. I think that it is about money, but why is it that mental health is the thing that suffers, as opposed to, cardiac health or, liver transplant or something like that? And, the obvious things to me are that it's, the shame associated with things wrong with the mind, our ongoing failure to accept that the mind and the brain are connected to the rest of the body, and and the fact that mental illness is not so visible, and there's not a standardized litmus test, and so insurers have always, I think, feared that there's going to be, if you let somebody get treatment for mental illness, it's going to be a continuous drain. They're just going to keep, taking and taking. as opposed to recovering. So, yeah, I totally agree that it's about money, but I think that everything having to do with mind is marginalized, and I think that people who have mental illness are the least able to advocate for themselves, especially when they're children, because they have, you know, all those additional systems around them, the family system, the school, social services, Department of Corrections, that may, you know, all have to be convinced before the child is eligible for getting treatment.
I wanted to add a comment here about stigma or the particular assault on mental health. And I think you have to link this to the assault on thought or the assault on subjectivity in a larger context, or No Child Left Behind, the assault on development, or even psychoanalysis more generally, which is about free thinking, ultimately. That there is a larger thematic sort of a cultural exploitation, assault, call it what you will, oppression on any kind of expansive or thought that may oppose the dominant culture. So whether you got No Child Left Behind in terms of teaching to a test and stifling creativity, stifling expression in the classrooms, or whether it's in the context of the oppression of I hate to use the word mentally ill, because even using that word, there's a certain kind of compartmentalization and a boxing off of people, as opposed to looking at people both in terms of their individual distress, but also the commentary on the larger culture, what it says when there are so many people who are in various states of disarray and distress. There's a larger cultural problem embedded in that when you have the prisons as a warehousing of not just the people with mental distress, but of anybody who is at a lower socioeconomic level and marginalizing any kind of protest in that way. So I think we have to look at these things in a more broad, social context, that it isn't just simply mental health per se, although that's part of it, but it's any fallout from the system and some way in which the system itself functions to keep people from thinking too broadly, because it's a threat. Because if people start thinking, as Noam Chomsky talks about, it's a very dangerous matter when people start questioning the status quo. And the people who profit from the status quo don't like that, so you don't want to give them opportunities to do so. And I think in that way you have to look at the larger system and what way these categories fit in.
Further questions?
I'm sorry, just one thing. Just feel free to raise your hand after the person and I'll give you the mic. Yeah.
I have a twofold question. One is that it seems like a lot of people, even with our very flawed insurance program, aren't that mental health that mental health doesn't cover a lot of insurance programs don't cover mental health. It seems like, or there's a limitation to it. And the second question I have is if you believe now that there is an epidemic of mental health problems. I mean, in the sense of, you think about all the gun violence and all the post-traumatic stress syndrome, the people coming back from these wars, and et cetera, et cetera. I mean, if you feel that there's a greater, is there a greater state of a crisis of mental health in this country now than what we've seen before?
I'm happy to answer the insurance question. So there has been about a 20-year battle that mental health advocates have waged to get so-called mental health insurance parity. This battle has been fought state by state and also on the national level. And just about 3 years ago, there was the renewal and expansion of the federal mental health parity law that, interestingly, prohibits insurance companies from discriminating in the level of coverage that they provide to mental illness in comparison to non-psychiatric illnesses. However, interestingly, it doesn't require the insurance company to provide any mental health coverage at all. But if you provide it, it must be done at parity. Now, that has turned out to be not the horror story that one might fear, because of the state-by-state battle fought by mental health advocates. And so here in Illinois, we have what started out to be an extremely pathetic state parity law. I say it's extremely pathetic because I wrote it. And after years of trying to get a parity law that I liked passed, we settled for getting a pathetic one passed. It was the most pathetic one I could think of. But it did pass without a dissenting vote. And then since then, every year we have strengthened it. And that law, and this happens in other states as well, that law requires health insurance providers to cover mental illnesses. And since in Illinois, health insurance providers must cover mental illnesses, then under the federal law, they must do it at parity. Now, the next thing is, because we fought a multi-year battle in Washington with all, basically it's one of the few things that almost every mental health group agreed on. We always just fight with ourselves because that's the way we are. But we agreed on this, and the Congress got smartened up about this. So when the Affordable Care Act was passed, that act includes parity both in the requirement for the essential health benefits and in the Medicaid expansion. So there are still plenty of problems. Several psychiatric groups have actually filed class actions in various states. It's against health insurance providers. It's appropriate, but that's because they're able to file class actions because there's now a law that they can enforce. So as I tell my students, if you pass a law that benefits people who are powerless, generally that's just the first step. The next step is you have to sue. If you pass a law that benefits Microsoft, the government will follow that law. So this is a battle we are winning, but we have not won, and there's plenty of problems. I get calls all the time from people who are being discriminated against in by their insurance over the coverage minimums.
Yeah, it was a problem talking at the practical and then the largest context, but to echo what Judy was saying before, the parity law was a step forward, clearly. But what?
It's a long way from perfect.
I would say it's an illusion that may prevent a larger scale social change. It's an illusion in the sense that while you give the medical necessity, the freedom to determine medical necessity to an insurance company, you have abnegated power. Medical necessity is a made-up thing. They came up with this. Now it's taken on this kind of legal force that somehow the courts have decided, well, yeah, sure, it exists. Well, there's no medical notion of necessity anywhere in any sort of clinical jargon or in clinical law. This is something the insurance industry invented so that they would have power to determine what they were going to pay for. This is the vehicle that they use to maintain power. Without the term medical necessity, they would have no power. They'd be out of business, in effect, because they couldn't control profit. It's about the control of profit, that you have to have a way of ensuring that we are only going to pay these claims and not those claims, or minimizing the ways money flows in and out of the system. So until the assault on medical necessity, that very concept is bridged, nothing much will change. The idea that parity exists is illusory. What they're doing now is cutting back levels of reimbursement to almost minimal levels in terms of outpatient treatments. They're still managing the benefits and determining what medical necessity is. And while they can do that, parity is an illusion because nothing was done to prevent them from making a final determination as to what is medically necessary. So in terms of the implementation, there's huge problems. And for people to think that this meant some real substantial change is quite elusive. To come back to the question then about the mental health problems in the country, there's actually less funding going on in terms of actual mental health services. Managed Care did a wonderful job in the 90s of eliminating mental health services. It used to be about 7-8% of the budget in healthcare. Now it's down to like 3-5%. So they did a wonderful job. In fact, almost to the extent that they put themselves out of business, that they had to relax a little bit and loosen up on the brakes. Now, the question you asked about the violence, it's a very interesting thing. You know, to me, and this is making a big leap, But when you talk about a culture under such siege, under such pressure in terms of the numbers of hours people work, the amount of stress people live with, the numbers of medication prescriptions that are given, the obesity rates, the lack of sleep, et cetera, to me, and the unemployment and so forth, something is going to explode here or there. So while in any individual instance you can look at this person or that person and say, well, the person's crazy, or they had a criminal background, or a terrible family, and that may all have been so. But when you look at the aggregate, I think you have to look at some of the larger social conditions that breed this, including our own culture of violence, which is, we go to war against the country, and we use drones, we operate all sorts of torture efforts around the world. We do all sorts of things in this country that we then disavow or dissociate and pretend that we're really okay because we're Americans and we have a certain exceptionalism. We can do all these things. So we split off our own violence and somehow act as if we really are above it all. And yet when things explode from within, we're very shocked and surprised, and we have to sort of isolate it and make it into a separate thing as some crazy individual doing something, and don't look at this ourselves as a country that breeds violence and is what one could argue is the major oppressor in the world.
I think another implicit issue here is got to do with the idea of sort of a psychoanalytic idea. Is there such a thing as human nature? Because to the degree that there is, and that we incentivize values that are not part of our own basic nature, that estrange us from our needs, if one conceives of people as having essential needs, that leads to an inherent tension between what we are actually creating in the society and what people are actually needing. So that I think within that gap, I think we've got some real social issues. It contributes to a context in which we're estranged, in which we create situations that are inherently frustrating. So I would add that as a comment.
There's an old quote by a fellow named Abraham Maslow, who you may know of, was asked about what kind of society does human nature allow for, and his response was, that's the wrong question. The better question is, what kind of human nature does society allow for? Because when we act from the idea that human nature somehow is preordained, that this is God-given, or it's just in the way it is, it's a kind of mechanistic, biologic kind of view of things, we limit political and social possibilities. We just wrote, it's just human nature, this is the way it is. So there's a dangerous kind of notion to reduce things to human nature and biologize them and mechanize them in that way.
Yes.
So I would like to ask, within the mental health industry, what are the incentives other than efficacy of cure that have made, for instance, medication so important vis-a-vis psychoanalysis? And how do short-term therapies fit in there? Like, what are the incentives that, other than cure, efficacy of cure, that have made the system sort of favor certain form of therapy versus others?
Talk about the money. So, I mean, the simplistic thing is that if medication is quicker and gets people out of hospitals faster, payers are going to prefer that. But the other complication which has been alluded to is, so there are lots of effective non-psychopharmacological treatments for people with mental illness, as people in this room know quite well. And the problem is, who pays for the research on those? So drug companies have an incentive to pay for research on medications. They have multiple incentives. One, they have to get approved by the FDA. If you're providing psychotherapy of any kind, and there are, as we all know, 10 million kinds of talk therapies, some of which are quite effective and some of which are completely ineffective. But even to do research on that, who will pay for that? Because it doesn't have to be approved by the FDA. If I want to introduce a new drug, I have to get it approved by the FDA. Therefore, I have to spend a whole pile of money on doing research to demonstrate to the FDA, correctly or incorrectly. We often find out that this evidence is less than it first appeared. But that's the problem. And because we have seen this, then I do think it really is because we start with the word MED. And people, that MED also ends in ICINE. and people think of medicine as medicines and not talk. And so it's a culture, it's a funding mechanism, it's a research question. I mean, there are research programs that have demonstrated that. For example, assertive community treatment is highly effective. Supportive employment, highly effective. But it took us a long time to prove that because no one wanted to pay for the research.
Can I follow up shortly? From within the provider, the doctors, recently I was told that if you are a psychiatrist giving medication, the fees that you get paid from the insurance companies are significantly higher than if you do like non-medication treatment. Which means that it will also be an incentive from the hospital side. Is that right?
Yes, because it's quicker, so it doesn't take so long.
I agree with that. I think that they would. It's like if they're talking, it takes a while to develop a relationship, and talk therapy is based on relationship. And if you're paying per minute or per hour, and if a doctor can see 6 patients in an hour and prescribe medication, that's a lot more treatment than 6 hours, or let's say 6 times 4 sessions, 24 hours worth of therapy.
It's also
just to say how does community mental health delivered all over this country for people with serious mental illnesses? They're seen by a doctor once a month for 5 minutes, okay? And then they're seen by social workers, or what I would call social workers light. They're not even, they don't have an MSW many times. So that we're delivering health care to poor people with the most serious mental illnesses, with people who have the least credentials, the least training. Some of it is highly effective because if it's in fidelity to some model, like assertive community treatment, but a lot of it is just, that's what we will pay for, and we will pay, Medicaid will pay to see for a doctor, doesn't have to be a psychiatrist, to see someone and check on their medication once a month.
It seems that the story that Patrick told about the recovery was a story that worked, and a story that certainly has implications because it has a deep respect for the person being served. So that I wonder why we consistently kind of look at, for example, a diabetic. We don't say, well, he'll build the system because he's taking too much insulin. But we see that with a person with mental health problems is going to build the system because he's getting something he didn't really deserve. Where does that notion come from, and why do we adhere to that?
Oh, anybody else?
Well, I think it's what Allan said earlier, that it's it's kind of a cultural suspicion of thought.
I couldn't agree more with what I said. It's an easy. They're easy to pick on, if you will. It's the most vulnerable, we have a tendency to go after the most vulnerable. It's low-hanging fruit, so we'll go after it. Even though we know that here we would know that, but the people who make the rules, as Gordon Gekko said, we don't do anything, we just make the rules. You have to follow the money, and see who exerts the power. And the answers to that become obvious, whether it's the pharmaceutical industry, the insurance industry, employers want things to be a certain way, et cetera, because they're making the rules, by and large, and we are the consequence of it. The interesting thing about money, too, is that, as we talked about earlier, the programs that actually are effective in terms of housing and economic employment and so forth, and the final analysis would save money. But it's short-term profit for the insurance industry. They're not going to pay for that because they don't make a short-term profit, and they know that everyone they cover will have a 1 in 2 chance of not being someone they cover next year. In other words, 50% of everybody in this country changes insurance every year. So there's absolutely no incentive for them to stick to the long run. They just, whatever's going to be the cheapest, because they know the likelihood next year is not going to be covered by us, they're out the window. The other thing is that in terms of efficacy, we also know that longer-term talk therapies, depth therapies, do have longer-term results. Medications may be helpful in the short run, but we know there's plenty of evidence to that the longer-term talk therapies do result in better outcomes, if you want to use that word, that people do feel better, people do function at a higher level. So we know that. So it's, in a certain sense, it's cost-effective, but again, we're talking about short-term profit.
So I have a quick couple questions. Did you have a...
I just want to say, I think it's important also, somehow there's been too much, for my taste, emphasis on the psychoses, the so-called mentally ill. And that's all true, it's all very important, there's no question about it, these people are getting shafted, our society is being shafted because of that, but this is not the most important problem, and it also is not really the important focus for psychoanalysis. And what you have in psychoanalysis, for my money, is actually research which does not have to go through the FDA, which is extremely powerful in developing all kinds of psychological, socio-psychological, analytical tools for having a very wide-ranging effect in this society. And it has not been, up till now, it's been contracting, not expanding in its existence and in its presence. When I started in 1965 in child welfare and on into agencies, psychodynamic theory was standard operating procedure. It's all gone now. It's all behaviorism. It's what it is suppression of problems. It is analogous in my mind to the bridge in Minneapolis that collapsed. What they're doing is that they are spending infrastructure money. They're doing everything that saves money now, and it's going to be very expensive in every respect later on. That, I think, is the future of psychoanalysis if we can do it.
So I have a quick couple of questions. One is about sort of the nature of the fantasy that Allan was talking about. So it seems to me that sort of Allan's talk and Mark's talk in some ways were about, how much it is we don't know, about how much things are really run by, to some extent, like moneyed interests and shaping the society as a whole. But I wonder, is it the fantasy that we don't know how things really work? Like, we have a fantasy, we believe that American healthcare is really great, we don't, but, really, here's the story. Or is it that, we do know, but sort of like what Neal was saying, we do know, and a lot of people know, but it's that, it doesn't seem to move us to action. Like there's maybe a pervasive cynicism or a sense that, our knowledge just convinces us even more about how impossible, actually achieving our interests are, so we become even more sort of wedded to the struggle for existence. So that's the one question. And then really quickly to Patrick, I would be interested if we could get a little peek at the 388, because I think you told a really interesting story about how these, progressive, anti-bureaucratic tendencies in the 60s and 70s got channeled into, again, like a further exposure of people to the war of all against all. And so the question then is, do you think there was a more emancipatory possibility at that period, or that there are sort of models in the present, or, was this was that to some degree an inevitable result of a certain way of conceiving of the problem at the time? I'm kind of curious about that.
Yeah. Where do we start? Let me make a quick one, then you go on. The problem of, it's an interesting problem of how much we can let ourselves know what's going on. And we can talk about lack of information. That's why I went through all this about the numbers to sort of present what's going on. But then how much do we take that in? And this is where the analytic questions become more prevalent. How much can we actually admit to ourselves that things really are the way the way the numbers tell us it is, or the way certain kinds of issues seem to be presenting themselves? So I'll tell you a brief story. Some years ago, I was the vice chairman of the city mental health board, during Jane Byrne's administration, during the flood. Anyway, I learned my politics from the chairman of our board, who had grown up in ward politics. Before that, I was just an academic, clinical person, whatever. Who didn't, you read stuff, but you don't really know. You don't really believe things are the way they are. So, Jane Byrne was up for re-election, and this was the time, of course, to try to get more money for mental health when politicians are most vulnerable. So, we called in the vice chairman of the health department, who was her person. There's always an MD who's in charge, but that's usually a titular person. And there's always someone who's the mayor's person inside each city department. So we tell them, okay, unless you get more money for mental health, we're going to blow the whistle on some damn item of corruption or another, and we're going to tell the media. And there was always some corruption, you could say. Because that's the nature of it. So, and we had lots of reporters who would write stories because they need to have stories. So we had this pipeline, and that was the power we had. And the election was the timing of it. So we told them, well, we're going to, she's got to give us more money, otherwise such and such and such. I never saw someone turn red so quickly. I thought he was going to have a stroke. I said, you can't do that. The next day, Byrne holds a press conference, $5 million magically appear for mental health. And that was, the way it works. But until you see that it really is the way it works, people tend to disavow it. Oh, we know Chicago's corrupt, or Chicago's this, oh, Madigan's doing this, the Daily, but we don't really believe it. We sort of write it off to a kind of TV show, that it's going to have some sort of, it's not really that bad, or in the end it's going to be okay, it's not, it ends nicely or something. So we don't really take it in, that it really does work this way, that it really is this really is the way things happen. And I think in terms of allowing ourselves to know that, it's horrible. It's really horrible to think that it really is, that the people in power really are not looking out for our best interests. They do only to the extent that we will force them to. But mostly it's about them and what is going to maintain their power. And that's a horrible thing. It's like growing. It's like being back in a family where your parents are really not doing a great job, and you're vulnerable to that kind of power. And that's the kind of terrible, terrible realization I think most of us are really frightened by and resist knowing about. So we go along with the fantasies and the illusions about how things really are. And this is, I think, also where the psychoanalytic mission can come in terms of how we know a lot about resistance. We know a lot about these things, about what can help people overcome their fears and resistances. If we would apply it to a larger context, I think we do a lot better with ourselves and the world.
I'm sorry, I just have to say something. It is horrible, but it's true, and there's a silver lining about government and how it works. And I'll say that after 23 years of formal education, the main things I got out of it are, one, I'm authorized now to say don't hit. And I can say that with a little clout. And two, I'm authorized to tell legislators, what's happening out here on the ground, so to speak. Because they just don't know. They came from whatever background they came from and whatever career they came from. They didn't all grow up going to school to become great lawmakers and learn all about health and, the mind and therapy and stuff like that. They rely on us to go and tell them what's what. And starting this spring in Illinois, you can now register your opinion, your support or opposition to any bill that's being heard in the Senate or the House of Representatives in Springfield by going to my.ilga.gov, and you can look up, whatever the law is and read all about it, and then you can create what they call a witness slip without even going to Springfield. It used to be, I think you had to go to Springfield and fill out a little slip of paper saying, my name is, John Brown, and I oppose this law. Well, anyway, you can be involved, and it's valuable. It's important, and it's a civic duty.
Jeremy, I really like your question about this idea is, well, essentially the way I understand it is how much knowledge is necessary to kind of prompt some sort of change, right? Because this really speaks to the theme about which direction forward. Is it by identifying more symptoms of this system, which we've heard about since the 60s, right? The symptoms of the system, the mental health system that's not working properly, right? We've heard about that for decades. So is the task at hand, I guess the way I understand it, and you talk about the fetishistic disavowal, which I think is really central. It's like, do we really need more knowledge generated on the symptoms, and with the hope that all of a sudden prompts us to change? Because, I mean, we can say the same thing about the education system. We've had all these kind of deconstructive analyses about, the problems with education and reducing students to just be filled with positive knowledge, and the only knowledge worth knowing is which is testable and calculable and so on. We've known about these symptoms for a long time, but nonetheless, we still kind of do them for a variety of reasons, because all these dominant structures that we're ensnared in. But yeah, we're at the level of practice. We know very well that there's problems with the system, but nonetheless, we still do the things that we should be doing at some level. So yeah, I'm really interested in that, because what will prompt some sort of transformation? What will be revolutionary in this? Is it through generating more knowledge, which then is inevitably kind of subsumed under kind of dominant structures, or what else do we aim for? It's not to say we should abandon all kind of enlightenment projects to generate knowledge, but it's to say, well, what are we doing with that knowledge, or what can we do, or what imagination does that serve? Does it just all fantasies? Does it just? So that for me is a key question, which I really enjoy. Which kind of so then you asked me about 388. My interest is it's a different way of conceiving the subject. And that's kind of the whole thrust of kind of what I was trying to present, is that the subject is infantilized, essentially, despite all these proclamations about recovery, saving the subject, and putting them in the position of the expert. It actually still kind of just moves them along. They're an object of care. They're either an object of care, whether it's through kind of biologizing them, which inevitably happens. But this idea that, within Hemsworth specifically, I can say, that inevitably this is kind of a surveillance situation. And they're taught, how to take care of the body. They're some of the most medicalized consumers, people. But they are medicalized. Every time I'm there, there's always appointments for one thing or the other, whether it's dealing with side effects of medications or, something, injury or so forth. They're so heavily medicalized, and ingested, thrown meds at and so on. So yeah, I am interested in 3-8 because it encourages kind of, okay, well, how else? What? It raises the question for me, well, why is the subject worth rescuing in the first place? That's a fundamental question. What is just kind of this humanistic concern for the other? Why rescue the subject? So for me, that speaks to, well, to answer that question, I would say, in brief, why rescue the subject? Well, I can think of no other site of freedom, no other site for ethical choices, no other site for a more holistic healing. So yeah, I think the subject is worth rescuing in some way. So I think at 388, yeah, I'm very much interested in it because there's a different set of choices available, and I think there's different types of outcome. And probably another talk I'll meditate a little bit more on that, but they are certainly, and I know Allan knows quite a bit about, they are certainly within the structures where they're expected to produce outcome numbers. They've gone up against, I believe, funding concerns from the Quebec government or Canadian government. They've gone up against big pharma out there as well. So they're certainly within the structure, but they still have managed to find a way in which to offer a different type of treatment, a different way of thinking about the subject and what is helping them and so on. I don't know if that really gets it. Okay.
Could you send us if we're interested, can we give you our email address and you send us your paper?
Absolutely.
There's one last question here, and I'm sorry we're going to have to cut it off. I'm really sorry, sir. But unfortunately, we're already late for lunch, so let's take this last one, and then, continue.
I'm just interested in your thoughts on... Okay.
Got it.
Some of the inertia in our culture politically, and wondering if when people, I guess, like us, have acquired the knowledge about how the system really works, have we already become power holders in the system, and therefore it would go against our own self-interest to change the system?
Now we come to the psychoanalytic questions, though. It's a great question, but and of course it's inevitable. Look, I make a living in a private practice, and people pay me a lot of money, to talk to them. And then you say, well, you are part of the system. Of course I am. But what am I supposed to do? Become Francis of Assisi? I'm not sure that's going to help anybody. I think these are the dilemmas. You have to hold two things at the same time. And this is also a kind of psychoanalytic, something we know about, how to hold competing or conflicting or different kinds of thoughts or feelings or realms of thought or experience at the same time and sort of weigh them out as best as we can. So yes, of course, we do have a stake in the system, but we also try to know where that may be and to rise above if that's consistent with what our values are. But it's a very difficult dilemma because inevitably, when we gain some power ourselves, we're reluctant to let go, whatever form that power takes. But our own awareness of that and our own striving for something better, I think, is what has to ultimately guide us. And I'm glad you're all here to ask these questions, and it's wonderful that we're having this conference and that people can begin to look at these things at this level, which to me is a historically very meaningful thing. It's almost like an indication that people are wanting to know more about what is going on, about what really, and how we can penetrate deeper, because that's really what the psychoanalytic mission is